We're excited that we have Dr. Benson with us today to address the topic you see on the screen. Before I introduce her, I want to do two quick announcements. The first one is about our annual Friedman lecture. It's about the intersection of climate change and population aging. And we focus on older adults and their experiences with climate change, as well as older adults as climate activists. It's going to be a great morning with some awards given as well. So please check that out and on our website, or you can scan there for more information. It's free, open to the public, and it's on the Danforth campus. Next announcement is our last...
it doesn't matter about the speed.
Oopsie. Yeah, our last seminar of our series is in May, and you can see that we have Tammy English and Renee Thompson from our Psychology and Brain Sciences department at WashU talking about emotional well-being and depression across adulthood. So check that out. We hope we see you there. And now I'm going to turn it over to our guest and introduce Dr. Benson. And before we get started, I want to remember to say you can put your questions in the chat. Natalie and I will be monitoring them over time. You can also just ask at the end, but if you want to put questions in chat, we'll wait till the end to deal with them. So thank you, Jackie, for being here. Dr. Benson is an associate professor of medicine, the Division of Palliative Medicine at the School of Medicine at WashU. Excuse me, she's a family gerontologist who focuses on psychological and social lives of older adults and their caregiving families. She focuses on testing and implementing psychosocial and behavioral interventions. She's focusing on outcomes of healthy lifestyle, positive family connections, better mental health. We're excited to have her here today. The name of her talk is Family Dynamics in the Context of Serious Illness Among Older Adults. So with that, we shall let Jackie get her slides up and remind you all to please stay on mute so that we can eliminate some of the background noises. Thanks so much. Jackie?
How does that look? Can you see my slides okay?
It looks good.
Okay. Well, thank you, Nancy. That was a generous introduction, and thank you all for being here today. I know you have a lot of choices for how to spend your lunch hour, so I'm really humbled that you chose to spend it with me to learn a little bit about family dynamics in the context of serious illness care for older adults. Before we begin, there are just a few things I'll address. I have no conflict of interest in relation to this presentation to disclose to you today. And second, I would be remiss if I didn't mention some of the incredible people I get to work with here at WashU, and certainly beyond, who share my passion for caregiving research and improving serious illness care. There are a lot of people to mention who are responsible for inspiring me and working with me and mentoring me. But I'd like to, at the very least, acknowledge my fellow researchers in the division, Drs. Parker Oliver, Washington, and Mayahara, and then, of course, our lovely and very talented research staff. Finally, considering the subject matter of my talk today, I like to mention my family. Of course, like all families, we have our own complex family dynamics, which I, of course, thought about near constantly as I was creating these slides. And so you might imagine when you study families and teach about family dynamics, your own family can't help but be a source of your inspiration. So mine certainly is for me, especially my father, whom you see pictured here. This picture of us was taken about a year ago before he passed away from esophageal cancer in 2019. And caring for him, I have to say, very certainly made me a better caregiving researcher, and I really like to think a better person too. So I couldn't talk about family dynamics today and families just in general without mentioning him. So a few objectives today I'd like to meet in this next hour that we have together. First is to introduce you to family systems thinking, and in the hopes that it'll inform your research or your practice with caregiving families of seriously ill older adults. Second, I want to define family dynamics. So we all have some shared meaning around this concept. So this will also include describing what theorists and researchers have determined are the main of family dynamics, a more formal understanding of it. But of course, we have casual understanding of family dynamics in a way we talk about it that are certainly pertinent. And I actually think, not in every case, but in this case, the way we talk about family dynamics in everyday talk does generally capture the way that we think about it in the research space. I'll summarize the evidence base on family dynamics in the context of serious illness care, and I'll wrap up by providing you a few tools you can use to assess family dynamics in your work. And finally, because family conflict is a common issue in families, especially when facing a major stressor like a serious illness diagnosis, I thought I'd provide some strategies that you can use in your work to help diffuse or prevent family conflicts as they relate to caring for older adults who are coping with serious illness. So just to provide some initial grounding on family dynamics, and we'll certainly dive into it deeper, as I mentioned, talking about the dimensions of family dynamics. What I mean by family dynamics in a nutshell and how we talk about them kind of casually is the inner workings of families. So just formally, they're the patterns of interactions among family members, their roles and relationships, and the various factors that shape their interactions. To set the stage further, I think it's appropriate to orient our thinking toward the challenges that families face when they're caring for an older adult with a serious illness. So in this context, family dynamics are really quite important to understand because they can be influential not just in our care planning, but also just selection of interventions or referral of families to interventions to support older patients and clients. So in sense, of course, family dynamics then both impede, but also can aid efforts to manage the challenges these families face. I think we can all agree here that the stressors are numerous. They include physical, emotional, psychological, relational, talk about that today, financial burdens. And I have here just a list of some of the challenges that our team identified in a recent study. We asked caregivers of palliative care patients who are facing cancer. The majority of these were patients over the age of 60. We asked these caregivers what their top 3 challenges were in delivering care. And this list here represents some of those responses. You can see they're quite varied. Some are specific to patient outcomes, whereas others are more caregiver focused. And I would imagine that you are familiar with many of them, if not all of them, in your own work. What I hope to do today is just provide some theory and evidence-based understanding of the ways where family dynamics can influence these caregiver patient outcomes. And of course, hopefully, if you don't already, you'll begin to apply a family system lens to your practice when you're providing care and support to older adults in your varied settings, whether that be in the clinic or in other spaces where you're providing aging services. So what do I mean by a family systems lens? So systems thinking can help orient us to this thinking around symbiosis. It helps us understand the symbiotic relationship of family dynamics and, of course, patient outcomes. There's this interaction and interdependency is really key to systems thinking. On this slide, I have a couple images depicting arguably probably the primary theoretical frameworks or lenses that family scientists and family practitioners use to direct their work with families, and also just frame their understanding of family dynamics, particularly in the research setting. So these frameworks are, you see on the left here, this is the socio-ecological, or you might have heard it referred to as the bioecological model. And then on the right here is an image depicting family systems theory, which I'll explain in a moment. not going to go into great depth on these theories, except to say that both of these frameworks are grounded in systems thinking. And they're, of course, often used to guide research and practice with families specific to healthcare settings. A key takeaway of these systems thinking theories is that context is highly important to understanding behavior and to identifying points of intervention. So with the socioecological model there on the left, the one with the embedded circles, I think the importance of context is probably fairly easy to see there just by looking at the figure. You can see these various factors. What this model is considering is the complex interplay between several systems here that depict the individual, personal relationships, community, and societal factors. And one of the things that I really like about this model is that it widens our thinking about family interventions in healthcare settings beyond the individual or the family level, looking towards structural factors like healthcare policy, for example. It helps us recognize and just address the structural inequalities that might exist and are good points of intervention so that we can help families who are navigating this illness. Today, I'm going to focus mainly on one of these system levels, the microsystem, that's the pink circle there, which you can see includes the family. And that's where I'll shift over to the image on the right, the mobile, which is where we're narrowing. I like to think of it as like kind of like narrowing the aperture on the bioecological model to that microsystem level specific to family and interactions between the individual and the family. So a mobile image like this is often used to represent family systems theory because each object in the mobile can represent a family member. And so the way a mobile functions, of course, is if you pull on one of the objects, all the other objects will move. So they're interdependent. And this concept of interdependency, that an individual in the family is subject to those pushes and pulls of the system, is a really key principle in family systems theory. And another key principle of family systems theory is nicely depicted when we think about the mechanics of a mobile. And that's its natural, the family's natural tendency, the mobile's natural tendency to maintain balance or stability, otherwise referred to as homeostasis. So according to family systems theory, families are constantly using feedback or information about the family system to monitor and self-correct. So therefore, the ability then to develop and maintain homeostasis, that balance, is essentially dependent on family dynamics or the inner workings of a family system. So based on decades of work theorizing and examining family interactions, scientists have conceptualized family dynamics in terms of three central dimensions, and those are cohesion, flexibility, and communication. Family cohesion and flexibility are the dimensions that summarize the functionality of family systems, whereas communication, that third dimension, is considered a facilitating dimension. So that means that with good communication, families are able to alter their levels of cohesion and flexibility to better deal with developmental or situational demands like a serious illness. And when we talk about cohesion and flexibility in families, we're talking about them in terms of how they're considered to be balanced or unbalanced on those two dimensions, cohesion and flexibility. So we'll take a look at each of these dimensions more closely, and then I'll summarize the evidence as it applies to our understanding of each of these dimensions in the context of serious illness care for older adults. Family cohesion, I'll start with that. It's defined as the emotional bonding that couples and family members have toward one another. So it includes shared decision-making, shared interests, and family togetherness or shared time. A family, as you might imagine, can have too much cohesion, which is what family scientists describe as enmeshed, or they can have too little, that's being described as disengaged or disconnected. family flexibility, that second dimension, is the amount of change in family leadership, in family role relationships, and family or in relationship rules or family rules. So accordingly, as you might imagine, negotiation styles are a key concept or issue here. The focus on flexibility is on how family systems balance then stability versus change. And so you might imagine, again, the ability to change when appropriate is distinguished by more functional families from dysfunctional ones. And finally, communication. This is considered critical for facilitating movement on the other two dimensions, so creating that balance. And when we examine communication, what we're doing is we're examining such things as listening skills. And by examining, I'm talking about in the literature of the family communication scholars. These are the kind of nitty-gritty aspects of communication they research. And listening skills, self-disclosure, empathy, problem-solving skills, which I think we all know are a big part of end-of-life decisions and caring for someone with a serious illness. And I want to say, as you might suspect, research has found that balanced systems tend to have very good communication. So families who communicate well, very balanced on flexibility, very balanced on cohesion, and unbalanced systems tend to have poor communication. And among these three dimensions, family communication is perhaps the most widely studied because of its because it is an explanatory factor, as I just described, and it has great intervention potential. So you might be wondering how we can assess family dynamics to determine what may be the root cause of family conflict, or thinking back to the slide at the beginning where I listed some of the burdens that caregivers reported that we had found in a study we recently did. How might family dynamics be an influencing factor for some of those challenges? And how do you assess that? And on this slide, I have a few formal or maybe formal-ish assessment instruments that you might use to learn about family dynamics or an older client's family dynamics when you're meeting with them one-on-one. First, and here's where they're a bit formal-ish, I'll say, is genograms. You may or may not be familiar with these. They are visual representations of a family tree that can depict relationships, medical history, other relevant information about family members across multiple generations. So the image to the right is actually an example of a genogram. It's pretty detailed. They can be far less detailed. You can ask a client, depending on the setting and the time you have, to complete something like this, to provide just a brief key of to use. More often, I just really interview an older adult that I'm working with and quickly sketch a genogram myself. Second here, I have relationship timelines or family timelines. They can also, like genograms, be as detailed as you want them to be. I actually like using them casually as well with older clients, just verbally asking them to report important family events. Or sometimes I can ask them to draw them, but generally I do that throughout the intervention and just plot them on a line. If you've heard of journey maps, you might think of them that way as well. And finally, there are a number of surveys. I'll mention just a few here that are probably most commonly used and are considered to be well validated. I will say, though, that how easily they can be used to assess family dynamics of older adults is somewhat of a question. So if you're interested in a really detailed review of these measures, you want to get into the nitty-gritty of which ones work best and some of the specifics about how they've been validated and for whom. I want to direct you to a paper published in the Clinical Gerontologist by our very own Brian Carpenter, who is a co-author, where they reviewed, I think, all the surveys that I've mentioned here and many more in the context of their use in late life families and how effective they are for capturing dynamics in with older families. So the first instrument I have here is the FACES-4. It's the Family Adaptability and Cohesion Scale. It was developed to capture the balanced and unbalanced levels of cohesion and flexibility in families. It's very shown to be quite valid, reliable, but as I sort of alluded to, this is a lengthy 62 items, so it really limits its utility and uptake in clinical and research and even research settings as well. The family assessment device that I have listed here second, it's also, unfortunately, another lengthy scale at 60 items. It's designed to measure an individual's perception of his or her family. I just want to interject that you might be wondering, like, why share such lengthy surveys that that we couldn't possibly use in a clinical setting. I do think, the goal is not to diagnose, to provide a formal diagnosis. If the goal is really to understand what the general dynamics are and kind of get a sense of who you're working with and the families you're working with, I think reviewing these surveys and just selecting some of the items to ask as a way of almost constructing your own interview guide can be really helpful. But certainly if you have the time, they're quite valuable and valid to assess dynamics if you administer the whole scale. Finally, the family environment scale. I like this one because it's specifically for counselors and researchers as well. Gives them a way of examining each family member's perception of the family in 3 different ways. So as the family is in real time, as it would be in a perfect situation, so ideal, how it's idealized, and as it will probably be in new situations, so as is expected. I really like measures that allow you to compare responses across multiple family members. There aren't a lot like that, so that's a good one to check out. So on this next slide, I'll talk about informal assessments. I think we could spend a good portion of the hour just talking about these informal assessments or way to formally interview family members, older adults about dynamics. I think the informal approach is really what we most often use in the clinical setting, given the time investment of the formal instruments I just mentioned. So just to give you a few tips or ideas and some questions you might ask, I think a great, what I'll call a grand tour question to start out with is just asking your older client to tell you about their family. And that lets them decide what they want to self-disclose. And we can also usually get a lot of information just from that one question, and then just fill in the gaps with a few of the follow-up questions that I'll mention. Typically, in a response to that, if you think about your own response to being asked a question like that, we share some demographics, we talk about family structure, maybe marital history for ourselves, and others, sometimes history of divorce, especially if any of these events are in recent history. And we talk about these dimensions in informal ways of cohesion, of flexibility, relationships, roles, who's the leader, who's the peacemaker in the family. We all play different roles in our families, and sometimes we describe that depending on the context. So it can be a great question to start out with. There's just, I think, 5 questions here that I'm highlighting. I think they're particularly effective in gaining important information for understanding the context of care at home. The first one being, who is involved in your care at home? This question obviously helps identify key family members or caregivers that are involved in the patient's day-to-day care. So I like that one. How do you and your family members communicate about your care needs? So this is tapping into that communication dimension, right? It explores communication patterns within the family. It can help you identify effective communication strategies they use or areas for improvement. Third question, how do you and your family members make decisions about your care? Understanding, I don't think I have to convince you that understanding decision-making processes within families can help you identify potential conflicts, which we're going to talk about in a moment. It can also help you identify areas where additional support are needed. The next question I think is important to ask to gain some insight into dynamics is to ask about cultural or religious beliefs that influence the individual's families, the older adult's family approach to caregiving. Exploring these cultural religious factors just helps, of course, us understand the patient's values and preferences regarding care, but also if you follow up with a question, to ask about how other members of the family lift up their cultural religious factors or use them to inform their decision making, you can recognize discrepancies across generations, which is sometimes common with immigrant families and where the cultural factors can make an impression to varying degrees. And then this last question I want to highlight, do you have any concerns or challenges related to your family's involvement in your care? This is just a really open-ended question, allows patients to express any concerns or challenges they may be facing in their caregiving situation. It's a great kind of wrap up to make sure that you didn't miss anything. Of course, there are questions you can ask. These are some that I just think are particularly effective, and love to talk about these at the end if you have others that have worked really well for you. I think it's a great time to share those with each other. Okay, so now that you're armed with some assessments you can use, both formal and informal, I just want to briefly summarize what we know based on using some of these assessments to measure family cohesion, flexibility, communication. So what is the evidence base of studying these dimensions within families caring for someone with serious illness? In terms of family cohesion, we know, no surprise probably, because I think I've really primed you to expect this, higher levels of family cohesion, research is really clear that these high levels are associated with reduced caregiver burden. And of course, improved patient well-being, because those are quite interdependent. We know that cohesive tend to engage in effective communication, in effective collaboration, in decision-making processes, and that contributes to better outcomes overall for patients and caregivers. Flexibility in family roles has also been studied quite a bit. Adaptable family structures is something that has been deemed to play a crucial role in responding to changing caregiving demands and also maintaining or allowing for the redistribution of caregiving responsibilities. So along with that, coping strategies as well to address challenges of caregiving, we can take what we know from the literature on flexibility and apply that to our work with families. And then last, communication patterns. Research is clear that supportive communication among families is linked to reduced caregiver stress and improved coping strategies. As I guess review at this point, we know that effective communication facilitates those dimensions. So it's facilitative of shared decision-making. It enhances family support systems, and it also ensures that the preferences and needs of the older adult are understood and addressed. So communication patterns, as I mentioned, are widely studied and critically important. So what questions remain, though? There are, unfortunately, still several gaps in the study of family dynamics and serious illness care. One of those is longitudinal studies. We have mostly what exists are cross-sectional studies. They provide snapshots of family dynamics, of course, at a single point in time. That doesn't allow us to then understand how family dynamics change over time, especially in the context of our conversation today, as the older adult's illness progresses and caregiving relationships evolve. We need to have a better understanding of the family dynamics and how they change. Diversity in cultural context, there's a lack of diversity in the population studied, very little representation of minority groups in varying cultural contexts. So future research really should explore those factors and how they influence family dynamics in serious illness care. This will help us, it will help improve adaptations of currently existing interventions and developing new ones to fit their unique needs. Measurement tools, there's a need for standardized and validated measures beyond those that I shared with you today to assess family dynamics in an intensive manner. So FACES does that, where it's looking at several of the dimensions, but most of the existing measures just focus on specific dimensions. So just cohesion, just flexibility, just communication. So comprehensive tools are needed, especially ones that can be used in this context of serious illness care. Those are certainly lacking. Caregiver perspectives. This might seem surprising because I think there's quite a bit of literature on caregiving, but we forget that much of that research focuses on primary caregivers. There's less attention paid to the perspectives of other family members involved in care. So siblings, adult children, extended family, fictive kin or chosen family are becoming more and more important, as they should be. So understanding the dynamics among those various family members or chosen family members can really help us provide or have a more holistic understanding of caregiving experiences. And interventions and support services. More research is certainly needed here to evaluate the effectiveness of interventions and of support services that are aimed at improving family dynamics, so aimed at improving flexibility, cohesion, communication. And we know that by identifying best practices for supporting families, promoting positive caregiving experiences, it's really essential to enhancing the quality of care provided. So lots of rigorous research is still needed here, not just to determine if interventions works, but importantly, how they work. We actually know very little about how interventions work, especially multi-component interventions. And we also need to know what strategies are most effective for implementing these interventions that we've developed an evidence for. We need to know how to get them implemented to assure their uptake and use in their intended settings. And then last but not least, end-of-life care. Still room for more research specifically focusing on family dynamics in this context. Understanding how family dynamics influences those factors we mentioned of decision-making, communication, and I think increasingly bereavement experiences during the end-of-life phase is really critical for optimizing care delivery in the end-of-life arena. There's a lot, I want to highlight, there's actually a lot of opportunity for research on bereavement care in particular. So there are folks in the Zoom room that have interest in this space. Just know that there's an opportunity for you to really make strides in improving bereavement care through continued research. I promised we'd talk a little bit about family conflict within families and between families. I'm going to mention just some statistics and describe the prevalence of family conflict. It often occurs in the healthcare setting. For example, in a study of conflict in ICUs, researchers found among 102 cases that 78% experienced at least one episode of conflict that either occurred within the families, between families and staff, or among staff as it related to families making decisions about patients' care. And in 24% of these cases, conflict occurred within the family. So that's the percent just specific to within family dynamics. And so you can imagine, like, what do you think most of these conflicts revolved around? Decisions about withholding or withdrawing life-sustaining medical care. Probably no surprise to those of you who are working in that space. In other studies specific to hospice, family caregivers, researchers have learned as many as 57% of hospice family caregivers do report episodes of conflict or what they might describe as tension with other family members. There was a study I conducted with our team, I have cited here in 2020. We found that nearly half of our sample reported episodes of within family conflict or tension, and the majority of those conflicts related to the dimension of cohesion, or also the frustrations, kind of gets at cohesion, the frustrations they experienced over an imbalance of autonomy and dependence, both as it relates to the caregiving role, but also the autonomy and decision-making power that the patient wished to have. So flexibility there. And of course, communication is a piece of that, because it facilitates our autonomy seeking and independence seeking. Other findings relevant to the prevalence of family conflict that I'll share here are that sibling conflict is especially common, and adult offspring of patients report more hostility and anger than spouses or patients. Compared to their parents, adult offspring actually tend to perceive their families to have poor communication, poor cohesion, and of course, as a result, more conflict. I'll be definitely curious to hear from you at the end of this talk if any of these findings on conflict align with your clinical experiences. On this slide, I just want to share some of what we've learned from research on common topics of family conflict at end of life. I don't think any of these are probably too surprising, and they sound familiar as you can see. Several listed that we've already talked about: treatment and procedures, medication use, life-sustaining measures, a lot revolving around patient care. So let's get into some strategies for managing family conflict. To start, I want to acknowledge there's definitely been a significant uptick in the study of family conflict in healthcare settings, but so unfortunately, little practical advice available on the subject of how to manage family conflict within this context. And even fewer interventions have been designed and tested specifically target family conflict in this setting. So where there is research, findings are pretty mixed. One example in one study addressing caregiving family support seeking families, the support-seeking families that were already in high levels of stress were more likely to reject help where help was accepted, and there was an increase in reported conflict rather than improvement. And in another review on grief interventions for caregiving families, this study, they found that several interventions were more likely to increase distress in hostile families. So these findings certainly raise questions about how to best support families in conflict. I will say, I think, one interpretation is that we just need to do a better job of assessing family dynamics in the outset. So no surprise, it's my first suggestion here is to start with family assessment so that we can select and design interventions that are better matched to their needs or circumstances. Connecting back to some of the formal assessments I reviewed earlier, genograms or family trees, those can help us understand who's in the family. It's always important to start out there so that you don't step on any landmines related to perspectives on who is in and out of the family by the perspectives of various family members, and helps you maybe identify where there might be tensions related to sharing caregiving roles and responsibilities and making decisions about care. And of course, if time allows, the surveys I mentioned can also be helpful to clinicians who are wanting to predict potential areas of conflict, identify discrepancies between generations regarding perceived obligations, and also in ascertaining beliefs about caregiving responsibilities. So those tools that we talked about a moment ago can all be helpful in addressing some of that and in comparing older adults' responses with their adult children. So of course, those comparisons can really especially illuminating. Second bullet here I have is the family meeting, the quintessential go-to effort for managing conflict. Of course, in these meetings, conversation and conflict management skills are essential. It's always advised to start with the patient, to ask who they consider their family, as I mentioned, to ensure that the right individuals are present at the meeting before you decide to host it. And then the remaining strategies I have here, I'll just put them all up now. Advanced care planning. Of course, if this has not been done yet and you can help facilitate ensuring that this planning is achieved formally and informally, can be a conflictual process, but it can prevent a lot of ongoing conflict or intensified conflict later on. Mediation and family counseling are suggestions for families, referring them to outside mediation or family counseling, or if you have that available within your setting. Education and information is really important as well. I think we kind of take it for granted, but a lot of conflict in families can revolve around just the unknown and people having various pieces of information and various levels of understanding about the disease and the prognosis. And so making sure everyone is on the same page regarding those issues, those topics, that information is really helpful. Spiritual and emotional support, of course, is very comforting to people and helping them manage conflict, sort of cognitively help them learn to cognitively reframe some of the conflict they're experiencing, especially if it can't really be resolved and they just need help managing it. A great suggestion to make. And of course, respite care. We know we're more likely to engage in conflict when we're tired, when we're overworked, when we haven't had the opportunity to take care of ourselves. And so especially when it comes to those who are directly involved in the day-to-day care, respite is really important for them. So this brings us to the end of my talk. I want to offer a few concluding remarks, though. Of course, if you weren't already convinced, I hope that considering family dynamics in the context of serious illness care and where you work, providing services to older adults, is something you believe, if you didn't before, is paramount for providing holistic and patient-centered care. It's a big part of philosophy of palliative care and hospice care, which is where my work is centered. And I really do think it's just a big part of any care provide to older adults, whether it's in a healthcare setting or not. So family dynamics is key to not just offering good care, but also understanding ways that we can enhance our care. Also, I want to mention again and just summarize how the research is really clear that family dynamics significantly influence decision-making. They have a huge influence on communication, on caregiver burden, and ultimately the well-being of patients and their families. And finally, I hope we can all agree that by recognizing and addressing the complexities of family dynamics, how they communicate, that level of flexibility within family roles and responsibilities and structure, all of that, by recognizing those things, healthcare providers are really able to better support older adults and their families, those care outcomes, and just provide a more compassionate and effective approach to serious illness care. So with that, I'll open for questions, comments, and love to hear folks share anecdotes relative to anything I talked about today, or if they feel moved to share a story relative to the topic today, that is always welcomed. So thank you.
Thanks, Jackie. That was terrific. Now we can see more people here. If you all have questions, you can do two things: put them in the chat or maybe raise your Zoom hand so we can be a little more. Come off of mute and ask a question. So thanks for doing those things. I'll start us off. I teach an aging class for MSW students. Mm-hmm. Christy does that with me, and I see she has been online. We just had a lawyer come in and explain everything about advanced directives, advanced medical care directives. Can you talk about where those things fall down? Because we know they do. I think families think, oh, a person thinks if I just get this paperwork in line, all will be fine. what has been your experience with how those work out and how to increase the chances of those working?
I think what's really key that we, that I've just witnessed, but also the research is showing, it kind of begins with designating who those proxies are. We tend to not think really hard about who really should be selected to fulfill those roles and make those decisions. So, I'll use my own family, for example, that just sort of automatically chose the oldest child, right, to do certain things. That's not uncommon. Or oftentimes the one that's primarily involved maybe day-to-day caregiving. But because your strengths in providing day-to-day care, because you have those strengths, doesn't mean that you have the strengths that are necessary to direct, final decisions about your health or serving as a proxy to make decisions financially on your behalf. So I would say definitely beginning with helping to encourage the older adult, in this case that you're working with, think through who would be the best person to fulfill those roles. And then secrecy is a big part of it too. For some reason, you see families not share with the entire family system, or that immediate family who has what role. So parents will tell their oldest child that they have a certain role, and sometimes even ask that oldest child to keep that between them, and the rest of the siblings don't know. And when are they found? But in a moment of crisis, which is never great. I'll say I do have I've worked with older adults who have, we've talked about this, and they'll say, and I can understand this too, that they'll say they'll be gone or incoherent at the time their family is fighting about it, so that they don't really worry about it. They just don't want to deal with the conflict while they're living. It's not that's not the approach I would recommend, but we do see that happen too. So those are some of the things that I would keep in mind in terms of like intervening, so that they are completed and that they are the interests and goals of the older adult patient in this case are really put forward and met.
Right. Thanks, Jackie. Let's go to Deb Schuster, who's raised her hand.
Hi, Deb.
Pardon me. I agree with you completely. The choice of appointees is so important, because I have many clients who automatically default to who is the eldest rather than based on skill set. And I think as an attorney who works with elder and end of life decision making, convincing the client that this is not representative of their love or respect for their children, but this is where they really need to be selfish and choose based on skill set. The other piece, when you mentioned communication, transparency, I really encourage my clients to allow me to put in there, particularly both the healthcare directive and the financial durable power of attorney, transparency language that says that whoever other than the spouse, respecting that, the privacy of that, but after the spouse serves, whoever is next serving shall consult and confer with everyone. Mm-hmm. And then for the financial durable power of attorney, that on a monthly basis, they actually provide copies of account statements, invoices, and evidence of payment, so that no one has to ask, so that it just is automatically forthcoming, because it protects everyone involved, knowing that the money is being spent as it should be on the individual, and just making sure that whoever's creating the document talks to all of their family members, even people they're not appointing, so to try to minimize discord and to really raise conversations. Also with physicians, because in Missouri, healthcare providers can, due to religious convictions and moral convictions and religious beliefs, not honor someone's end-of-life treatment wishes. And that's happened with 3 clients. So to really have those conversations with healthcare providers, family members, so that everyone has a chance to voice their concerns, etc., and possibly lead to a change in appointees. So thank you so much. This was a great presentation.
Thank you. Thank you for those comments. I really appreciated you kind of confirming those things. And I'm curious for you, question for you is how you help maybe mediate some of those conversations, or if you do, I would imagine that you have clients who ask you to be present maybe when they have those family meetings. Is that something you suggest? Okay.
And I do mediation regarding these issues. Quite a while ago, I had a mother that was residing with one of her daughters. And when we had the entire family together, because the mother's cancer diagnosis had then become terminal, and she decided that she did not want ongoing treatment. And the daughter with whom she was living said, I can't not call EMS if something happens. And obviously they'd never discussed this before, but the mother ended up moving in with the other daughter. And it became a very candid, very, very tearful conversation, but for everyone to really be upfront about their concerns and what they really felt capable of doing. So that happens a lot.
Yeah, thanks, Deb.
Thanks.
Jackie, you got a couple other questions, so I'm going to move us on looking at our time. Christy, do you want to come off and ask, or can you read Christy's question there, Jackie? It's about white knight syndrome. Information how the dynamic might impact family bereavement. Thanks, Christy.
That's a really great question. I love that question, Christy. I mean, are you I would imagine you're talking about between family systems. Do you mind share, or you can type in the chat?
You can come off Zoom, come off mute rather.
I could come off mute, but I've got a cold today, so I probably don't sound the best.
Yeah.
I just, in my experience as a hospice and palliative care social worker in the community, what I would often see, particularly with families with several adult children, is that there would be an adult child that would kind of pop in and out of the distant caregiving. And so they would come in and want to change so many things about the way that care was being done, or a medication list, or they would have just very strong feelings about, maybe some decline that they had seen in their parent. And then they would come to a care plan meeting, stir the pot, as it were, and then kind of leave again. So I didn't know kind of where that might be situated in terms of the family systems theory, and kind of what work has been done, and then how that might impact bereavement.
Yeah, I
a lot of questions at once.
Thank you for sharing that context and a little bit more information on that, because I was going in a completely different direction. So I'm glad you came off mute. That adult children who play that role, I feel like families with that have multiple, and someone's living at a distance, you almost always see some degree of that. And where I see that addressed in the theory and just with practitioners applying the theory is examining roles in the family. So I mentioned when I was talking, like people who play the peacemaker and people who play the decision maker, people in the family who play like the comic relief, who bring that. So we all have roles, and often what clinicians working with families to help understand some of these roles, that's the approach to resolving the conflict that results from this behavior, because you're likely not going to change it entirely. You can maybe ease some of it. You can help that person who's sweeping in and trying to make great changes, improve their communication about that. You make incremental changes, but you're not going to make huge changes in the moment of crisis like that. So what what the therapists who often use family systems therapist theory will do is use it to help families understand roles and just provide some shared understanding about why we behave the way we do. Because that often doesn't change behaviors, but sometimes when we know why someone acts the way they do and how we all kind of have our roles, it allows us to be a little bit more compassionate. And I feel like there was a second part to your question, or maybe did I address everything? How it might impact family bereavement. I said that the literature on bereavement interventions is really thin, and I'm not aware of this particular topic being addressed in the bereavement stage. I think that's a really great question to pursue and think about in terms of family interventions in bereavement. There's lots of practitioners on this call. I think we all know that families, caregivers, the surviving family members are often forgotten as soon as that patient is gone. I have caregivers say that they're just sort of left alone in the patient room, and no one's even checking on them and kind of ushering them out of the hospital or the hospital space. I guess I think it is better in other spaces. But hospitals are very busy. And so that happens. And we forget to catch up with families and provide those interventions. A big piece of that is because, and this is true, grief is a normal part of this process, right? And so there's varying degrees of interest, I'll say, in pursuing these sorts of interventions, certainly from the funding level, federal funding level, to study interventions like this. Is this really needed or not? So we're doing a better job of trying to, as researchers, trying to show, the case, provide a case of how often complicated grief comes up and ways to prevent that from, rearing its ugly head if we're not addressing grief issues from the beginning, from the get-go.
Great. Jackie, two things. One, we're going to be out of time in just a couple minutes, so people will need to start leaving. But let's try to get one more question, and if we go over, people can get off if they need. But Dr. McKinda, Keisha, do you want to come off and ask your question?
Sure. Hi, Jackie. Lovely talk. Thank you. My question is about conflict, which is very interesting to me, and it's kind of a two-fold question. What's your perspective about conflict? Like, can it be a positive thing? I'm thinking about, conflict can kind of promote one to have development, personal development, individual development. Can that be helpful or useful kind of for the growth and development of the family? And then the second part is about kind of the dimensions of conflict. I feel like all conflict is not the same. And so does the literature delineate different types of conflict? Is there a threshold, so to speak, of when conflict becomes problematic?
Great questions. I'm so glad you asked them. So to answer your first question, absolutely, conflict can be constructive. There's such thing as healthy conflict. I think in this space, why we often think about it in negative terms is because families are in crisis. And if you're applying family systems theory and thinking about how bad families are in terms of flexibility, in terms of cohesion, how effective their communication strategies are, when those tend to be unbalanced, when communication isn't good, conflict is pretty high, and it's not the kind of conflict we're talking about that can be very constructive. That's not to say, though, in those heated conversations, sometimes feelings, emotions are revealed. And if maybe on an individual level, there are family members who are better at receiving that message and sort of breaking it down to understand what really the root is, it can help build sibling dynamics, for example, in a way, especially after the parent is sick and maybe has passed, to reframe how they interact. But it can go in a negative direction as well. And your second question, remind me real quick.
It was just about the dimensions of, is there a threshold? Having different types of conflict.
So I like that you asked that as well, because that was one of the things when we did, I think the study I cited that we published in 2020 and reviewing the literature, conflict, its dimensions, its degrees really aren't delineated, haven't been delineated in the research. It's really studied in terms of like, is there conflict or isn't there conflict? It's a very binary approach to understanding it and measuring it in families. And at one point, you might have heard me say, reference conflicts, but also tensions. And we really attempted to acknowledge the fact that there are overt conflicts, arguments, but then there are these covert interactions and conflicts that kind of like simmer beneath the surface, many times can be worse or result to worse explosive kind of arguments and conflict if those aren't resolved. So there are but in the research, we just don't do a good job at delineating that. So great opportunity for folks who are interested in that.
Thank you.
Thanks, Jackie. There's a couple more comments in the chat, but I think we have to stop. But Joan does acknowledge the Conversation Project has a good booklet on healthcare proxy. So thanks for that comment, Joan. And others we're just not going to get to. This has been really interesting. I thank you for your time. And I sure hope that we see all of you next month for our next Issues in Aging. Thank you all very much.